dreaded disease in the world today, consuming hundreds of lives as we speak. But diabetes is just the tip of the iceberg. It's the underlying threats of diabetes that compromise and complicate the patient's wellness. The need of the hour is a therapy that offers wellness beyond diabetes control. In TAS, leaders in cardiodiabetotherapy unveils a new era of wellness for diabetes patients, introducing an innovative and holistic approach beyond glycemic control and emphasize heart and kidney protection. Dapavel, wellness beyond diabetes control. Indian phenotype T2DM patients in particular have multiple risk factors and are at high risk of cardiorenal complications. Transform their harsh reality into healthy possibility with Dapavel. Dapavel offers powerful glycemic control. Large studies have shown cardioprotection and renal protection with or without diabetes with dapagliflozin. Every sales pack of Dapavel shares your precious advice with the patient. Uncomplicate your diabetic patient's life with uncompromising quality and efficacy. It's time to offer them hope beyond possibilities, health beyond limitations, happiness beyond expectations. In T2DM with multiple risk factors, prescribe Dapavel. Wellness beyond diabetes control. Diabetes, one of the most dreaded disease in the world today, consuming hundreds of lives as we speak. But diabetes is just the tip of the iceberg. It's the underlying threats of diabetes that compromise and complicate the patient's wellness. The need of the hour is a therapy that offers wellness beyond diabetes control. In TAS, leaders in cardiodiabetotherapy unveils a new era of wellness for diabetes patients, introducing an innovative and holistic approach beyond glycemic control and emphasize heart and kidney protection. Dapavel, wellness beyond diabetes control. Indian phenotype T2DM patients in particular have multiple risk factors and are at high risk of cardiorenal complications. Transform their harsh reality into healthy possibility with Dapavel. Dapavel offers powerful glycemic control. Large studies have shown cardioprotection and renal protection with or without diabetes with dapagliflozin. Every sales pack of Dapavel shares your precious advice with the patient. Uncomplicate your diabetic patient's life with uncompromising quality and efficacy. It's time to offer them hope beyond possibilities, health beyond limitations, happiness beyond expectations. In T2DM with multiple risk factors, prescribe Dapavel. Wellness beyond diabetes control. Diabetes, one of the most dreaded disease in the world today, consuming hundreds of lives as we speak. But diabetes is just the tip of the iceberg. It's the underlying threats of diabetes that compromise and complicate the patient's wellness. The need of the hour is a therapy that offers wellness beyond diabetes control. In TAS, leaders in cardiodiabetotherapy unveils a new era of wellness for diabetes patients, introducing an innovative and holistic approach beyond glycemic control and emphasize heart and kidney protection. Dapavel, wellness beyond diabetes control. Indian phenotype T2DM patients in particular have multiple risk factors and are at high risk of cardiorenal complications. Transform their harsh reality into healthy possibility with Dapavel. Dapavel offers powerful glycemic control. Large studies have shown cardioprotection and renal protection with or without diabetes with dapagliflozin. Every sales pack of Dapavel shares your precious advice with the patient. Uncomplicate your diabetic patient's life with uncompromising quality and efficacy. It's time to offer them hope beyond possibilities, health beyond limitations, happiness beyond expectations. In T2DM with multiple risk factors, prescribe Dapavel. Wellness beyond diabetes control. Diabetes, one of the most dreaded disease in the world today, consuming hundreds of lives as we speak. But diabetes is just the tip of the iceberg. It's the
Good evening, everyone. On behalf of Intas Pharmaceutical Limited, I, Dr. Mithilesh Nayak, welcome you all to this ninth edition in the webinar series Spotlight SG LD2 inhibitor. And today we are going to discuss about its usage in two important day-to-day clinical scenario, that is the heart failure and chronic kidney disease. And to moderate and guide today's session, we are having with us Dr. S.K. Dwivedi. He's a Department of Cardiology at King George Medical University, Lucknow. He's a senior consultant, interventional cardiologist, electrophysiologist. He has guided many DM cardiology students and has numerous publications to his credit. He's, he was also organizing secretary for the ISC Con 2014, and he is a regular faculty in various national conferences in the field of cardiology. So with this, I hand over the digital podium to Dr. Dwivedi, sir. Over to you, sir.
Thank you, Dr. Mithilesh, for the kind introduction. So here, friends, we are today to talk about a molecule, or I would rather say a group of kids on the block, which are now in the medical news. For that matter, let's say a lot of specialties are concerned with this. Initially, diabetics were going gung-ho. Then on the bandwagon came cardiologists, and nephrologists also were not far behind. Why? Because this is a peculiar molecule. We are, it is now coming as in almost every guideline now, particularly for diabetics, as well as it has encroached upon cardiology, particularly in heart failure, and going on to encroach on the prevention of renal damage. Uh, so this molecule needs a special attention. Today we have two eminent speakers. First of them is Dr. Aditya Kapoor, who will be talking about the cardiac aspects, and then we have Dr. Sampath Kumar, who will be talking about the renal aspects where we can use it. Dr. Aditya is a very old friend of mine. He's a professor, and he is a wonderful speaker. He's a very wonderful speaker. We all see him in national and international meetings. His areas of interest are coronary interventions and electrophysiology. He has various publications. He is on the board of, he is already part of many guidelines of Cardiac Society of India. So he will be talking about what has been the role of SGLT2 inhibitors in cardiology, particularly with a focus on prevention and in the management, and how currently the literature places it for the management and prevention of congestive heart failure patients. Friends, we will have a question answer at the end of both sessions. So you may keep on writing on the chat box your questions as and when you come across or think about it. And then we will be discussing in the end. Remember, this will be a critical appraisal of the drug's role. It may or may not be what you think, what you read, or what you interpret the drug as, but it will be a very open and vivid discussion about how we should take this drug in our clinical practice. So over to you, Aditya, for your presentation first. We
Thank you,
all
sir.
have you.
Thank you, sir. Am I audible?
Perfectly well.
So I'll just share my screen. Are my slides visible?
Yes, they are visible. You can go on full screen.
I'll just go. Yeah. So it's always a pleasure to be on any forum with Dr. Dwivedi. I was telling Dr. Sampath Kumar when Dr. Dwivedi was just trying to log in that the importance of having Dr. Dwivedi on board is that he dissects everything very, very critically. Doesn't take anything at face value. So our job here is to discuss in the next 20 odd minutes what is the cardiology perspective of SGLT2 inhibitors. We all know that heart failure has a huge global impact, and any therapeutic modality, we want that it should improve the clinical status, the functional capacity, impact hospital readmissions, which is a huge marker of adverse outcomes, and reduce mortality. My slides are visible, na? Slides are visible?
Yes, yes, yes.
Yeah,
Clearly, clearly.
sorry. So the
Yeah.
current pillars of heart failure therapy are ACE/ARBs, beta blockers, mineralocorticoid receptor antagonists, and now of course ARNI. So we keep on, switching between these drugs, try multiple combinations. But despite this, about 4 out of 5 heart failure patients continue to have multiple admissions, and the 5-year survival rate is modest at best. So we need to look beyond this therapeutic armamentarium. The issues we'll discuss is the saga or the story of the SGLT2 inhibitors, touch upon declare TIMI58 specifically related to dapagliflozin and the DAPA-HF, brief word about the Emperor Reduce and the DAPA-HF, how they compare with each other, post DAPA-HF, what seems to be the exact place in therapy for this drug in heart failure, reduced ejection fraction, because this has now been endorsed by the FDA as well. We as clinicians want to understand whether combining these drugs with multiple drugs would be bad. What is the guidelines endorsement which Dr. Dwivedi briefly touched about, and final carry home messages. So once the EMPA-REG outcome, which was the first trial which showed favorable cardiovascular benefits of SGLT2 inhibitor, that was released, and that covered diabetes with established cardiovascular disease. The DECLARE TIMI58, which studied a almost similar patient population, diabetics who had established atherosclerotic disease, that is secondary prevention, or who had multiple risk factors, that is primary prevention. So this trial studied both patient population in established diabetes, studied DAPA versus standard of care, MACE outcomes, and a dual efficacy outcome of cardiovascular death, heart failure, hospitalization, and MACE. So it met the primary criteria for non-inferiority for MACE. DAPA was non-inferior in terms of MACE reduction. And the dual efficacy outcomes of cardiovascular death, heart failure, hospitalization was reduced. It was superior, in fact, to standard of care, primarily driven by reduction in heart failure hospitalization. When the declared TIMI58 data was teased out to find whether patients of heart failure benefited, unfortunately, only 10% in this declared TIMI58, about 4% had systolic heart failure, and about 7.7% had heart failure in which the ejection fraction was not documented. So only 10% had heart failure. Whatever the data was, when they teased it out, they found that in patients of systolic heart failure, all these outcomes, heart failure, hospitalization, cardiovascular death, and all-cause mortality, were impacted very, very favorably. But in patients without baseline heart failure, baseline systolic heart failure, only heart failure hospitalizations were reduced, cardiovascular death and all-cause mortality was not reduced. So the declared TIMI58 taught us that heart failure hospitalizations were reduced in patients with or without systolic heart failure. Cardiovascular death and all-cause mortality was only reduced in systolic heart failure, and the benefits were on top of the standard of care therapy available at that time. So it was an important trial, and it sort of extended the story, the unexpected story of SGLT2 inhibitors. We found that it had an unexpected benefit in the EMPA-REG outcome. So it extended that to a broader range of diabetic patients for both primary and secondary prevention, added to the safety data whichever was available at that time, and sent out a strong signal that preventing heart failure was possible in these patients who were at high risk. So then people started wondering that whether you can extend this therapy to the entire spectrum of heart failure as a therapeutic modality. And this was again possible because whatever data was available at that time from the SGLT2 inhibitor trials, the EMPA-REG outcome, the CANVAS, the DECLARE, and the VERTIS, all of them showed a consistent reduction in heart failure hospitalization to the tune of 30 to 35%. So it was a class effect. So as I said, people started wondering, can we use this drug as treatment for heart failure? And would this biology even work in heart failure without diabetes? Because heart failure and diabetes have a bidirectional relationship. Each independently increases the risk of the other. Heart failure is more common in diabetes, and diabetes is more common in heart failure. And very importantly, metabolic, that is dysglycemia, and vascular diseases like heart failure, they arise from a common soil which is driven by inflammation, lipotoxicity, dysglycemia, as I mentioned, which leads to insulin resistance on one hand and diseases like CAD, hypertension, and heart failure on the other. So they are both linked. And this is very, very important for us to understand the tight glycemic control in diabetes still leaves us with a residual vascular risk. So what do we mean by that? So if you see on this side, heart failure, MACE, and myocardial infarction. With intense or good glycemic control, the percentage of risk removed is this. So what do we mean by this? What we mean is that if you get the best of the glycemic control in diabetes, only 9% of the MACE risk is removed, only 15% of the MI risk is removed, and despite the best of the glycemic control, the heart failure risk is not impacted at all. So we need to look at some therapy which reduces the heart failure risk. And that was the reason the DAPA-HF trial was planned. That is, patients of heart failure with low ejection fraction, high BNP, DAPA versus standard of care, cardiovascular death and heart failure hospitalization were the primary endpoint. What was most important thing was less than half of these patients actually had diabetes. So it gave us an opportunity to examine whether the benefit of SGLT2 inhibitors would extend to non-diabetics as well. And these were the various endpoints. The first major endpoint, the worsening heart failure or cardiovascular death, was reduced by nearly 26%, which was enormous. Hospitalization from heart failure was reduced by 30%. And the most important thing was mortality outcomes. Cardiovascular death and all-cause mortality was reduced by nearly 18%, which was again an enormous step forward. Of course, symptomatic benefit was there. Second important carry-home message from this trial, because Dr. Dwivedi always teaches us that look at each trial very, very critically. So the curves separated rapidly. This was the temporal profile of the separation of the curve. The benefit was achieved as quickly as 1 month with SGLT2 inhibitors in heart failure. There was no significant safety outcome because we as clinicians are sometimes concerned about volume depletion with these drugs, of renal adverse events, which Dr. Sampath will of course describe, amputation, which was a concern in the CANVAS data, diabetic ketoacidosis, Fournier's gangrene. There was no difference. So the DAPA-HF concluded that the benefit was additive to standard of care therapy. The magnitude of benefit was similar irrespective of whether or not diabetes was there, which was again a very, very important thing. And lastly, the benefit was similar to and reminiscent of the benefits of ARNI in the paradigm heart failure. So what we remember from the paradigm, on the left side if you see, is the data from the DAPA-HF, and on the right is the data from the paradigm. Cardiovascular death, heart failure, hospitalization, all-cause mortality. In the DAPA-HF, it was 26%. In the paradigm, was 20%. And mortality was 17 and 16%. So on the basis of the paradigm heart failure, the ARNI, they found their way into the guidelines as an expedited class 1 recommendation. So on the basis of this data, 2 SGLT2 inhibitors also justify and expedite inclusion in the guidelines. So we'll again discuss this, but this should be kept at the back of the mind. Secondly, quick look at DAPA-HF and EMPEROR reduced. Both trials are there for heart failure patients. In terms of cardiovascular death, hospitalization for heart failure, or first hospitalization for heart failure, if you see, both data sets are remarkably similar, about 30 to 25% reduction. So both trials were remarkably similar. The only difference was mortality outcomes were significantly lower only in the DAPA-HF, not in the EMPEROR reduced. And the renal outcomes were significantly better in the EMPEROR reduced. So these are minor differences, but what we need to understand, as of now, the mortality benefit was only with the DAPA-HF group, probably because the patient populations were also different. So this is again what, Dr. Dwivedi, whenever we discuss any trial with him, he has said that always look at the data with a very, very critical eye. So this is probably the difference. The ejection fraction was a bit lower in the EMPEROR reduced, the BNP was higher, eGFR was slightly lower. So these patients were sicker. And the ARNI use was nearly 2 times, 10% here and 20% in the EMPEROR reduced. So this was probably the reason, but we should again understand as of now, mortality benefit in heart failure was only in the DAPA-HF. Whatever it may be, this was the superb meta-analysis by Zanad wherein they combined the data set from Emperor Reduce and the DAPA-HF and found that when you combine the data sets, all-cause death, cardiovascular death were significantly reduced by both SGLT2 inhibitors. Cardiovascular death, first heart failure hospitalization, and the renal endpoints were also significantly reduced. So both the data sets, when they were combined, another remarkable thing which was seen was that patients with diabetes and without diabetes were again similarly impacted, nearly 25% risk reduction. So the conclusion was that in patients with systolic heart failure, both trials suggested that SGLT2 inhibitors consistently reduce the risk of death, heart failure hospitalization, regardless of diabetes. So that is the second carry home message. Thirdly, now since the publication of the DAPA-HF, there have been various subgroup analyses which we should be aware of as clinicians. Diabetes versus non-diabetes, which I have touched on. I'll just briefly cover it. Can we give these drugs in older patients? Does it work across the spectrum of low EF? If the ejection fraction is say less than 25%, the patient is sick, can we give it? Is it ever too late to start SGLT2 inhibitors? What is the relation with duration of heart failure? So briefly covering this, as I said, 55% in the DAPA-HF did not have diabetes. So this is recent analysis of the DAPA-HF published in 2020. Both diabetes versus no diabetes, there was similar risk reduction, and a very elegant analysis was done. Patients who had no diabetes at baseline, they divided them into various tertiles of HbA1c. In euglycemic patients, there was no impact of HbA1c also. So it was not only independent of diabetic status, but in euglycemic patients, the benefit persisted across all HbA1c tertiles. It was well tolerated. There were no safety issues. Second important thing we want to understand is, can we give it to older patients? This is again recent analysis in 2020. About 1/4 of the DAPA-HF were more than 75. Because older patients, we all know intuitively, are at higher risk, the absolute benefit of DAPA in the DAPA-HF was also higher in the older patients. No safety outcome differences in terms of volume depletions or renal parameters. So advanced age alone should not be a reason to withhold this drug in patients of systolic heart failure. That is the important message. What about gradations of ejection fraction? People in the DAPA-HF, they were divided into ejection fraction less than 26% to more than 35%. The various 4 groups were divided. We all know each 5% decrease in ejection fraction was associated with worse outcomes. But again, similar to age, patients with lower ejection fractions, since they had higher risk, the absolute benefit of DAPA was also higher. Again, no difference in safety outcomes. So LV ejection fraction alone, a low ejection fraction, even 25%, less than 25%, should not be a criteria that this drug should not be given. It is safe and it should be given. What about duration of heart failure? Sometimes we think that the patient is chronic heart failure, he is doing well on therapy. So there is a therapeutic inertia. They divided the patients from DAPA-HF, recently published in the American Heart Association meeting, from various 1 year, 1 to 2 years, 2 to 5 years, and more than 5 years. What they found was that higher risk in those with longer duration heart failure, so benefit was also higher. So the assumption that these patients are stable and have little to gain from additional therapy is not true, and it is never too late to start therapy with these drugs, because it will not only reduce recurrent hospitalization but also reduce outpatient visits. Both of them have prognostic significance. Recurrent hospitalization, of course, have a higher mortality risk, but even outpatient visits have a nearly 3 times higher mortality risk as opposed to no outpatient visit. In the DAPA-HF trial, both these outcomes, recurrent hospitalization and outpatient visits, were significantly reduced. In fact, in this stable, well-treated heart failure population who was extremely well-treated with standard of care therapy, 1 in 8 patients experienced a worsening of heart failure requiring augmentation of oral therapy during outpatient. So our perception that the patient is stable and not doing well does not mean you should not change the therapeutic drugs. Would polypharmacy be bad? So we are concerned that if we combine this drug with, say, diuretics, mineralocorticoid receptor antagonists, ARNIs, will the patient have side effects? Again, sub-analysis of the DAPA-HF, when combined with diuretics, there was no change in the benefit, and very importantly, there was no issue of volume depletion or dyselectrolytemia. When combined with mineralocorticoid receptor antagonists, the benefits of DAPA were similar. In fact, the renal outcomes, hyperkalemia, was significantly less when DAPA was combined with mineralocorticoid receptor antagonists. So the carry-home message is that they can be successfully combined. And if you start, say, the SGLT2 inhibitors first, a good response to SGLT2 inhibitors should not deter you from starting the mineralocorticoid receptor antagonist later on. It will be better for the kidney. Thirdly, ARNI, because now this is also standard of care. About 10% patients in the DAPA-HF were on ARNI. And with or without ARNI, the benefit was similar. No difference in volume depletion or other safety outcomes. So again, the carry-home message, the benefit of this drug in the DAPA-HF was consistent regardless of the background therapy. So quickly summing up, what do the guidelines tell us? As Deepak Bhatt said in his editorial when the DAPA was published, this is a great victory in war against heart failure, the SGLT2 inhibitors. The FDA and the European agencies have approved it last year only. The European Society followed up in 2020 November with the statement that any of these drugs can be used for prevention of heart failure hospitalization, while based on the DAPA-HF and the EMPA reduced, DAPA and EMPA are now recommended for treating such patients. So what we need is now a multimodal approach. Multiple mechanistic pathways are operational. Each neurohormonal agent like beta blocker, ACE, ARNI, and SGLT2 inhibitor, they act on independent pathways and their benefits are incremental and additive. The challenge now for us cardiologists is how to sequence these therapies in heart failure. So as somebody very wisely said, now we have a transition from a famine of drug which was available to a feast of drug which is available for heart failure. We should not wait. We should not go by the traditional chronological stepwise order that first ACE or ARB, wait for a non-response, go to ARNI, then add some beta blocker, go to the maximum dose. So now the mindset is a quadruple therapy is a new standard of care. This is being endorsed by the Canadian guidelines, which say each of the following categories: ARNI, beta blocker, MRA, and SGLT2 inhibitors. Similarly, ACC in its February 2021 says ARNI, beta blocker, diuretic if needed, and quickly add SGLT2 inhibitor when the patient meets the eGFR criteria. In fact, now this is the latest review in 2021, where in beta blocker, ARNI, and SGLT2 inhibitor have been started as step 1 and mineralocorticoid receptor antagonist as step 2. And this tells us that if you combine these 4 drugs, you might add at least 6 years to a guy who's 55 years of age of heart failure. And if the guy is 65 years of age, you might add 4 additional years to his life. So it's very important that we keep these drugs in our back of the mind. And I'll sum up with this is a wonderful poll conducted by ACC in November 2020. Cardiologists, should they take lead in prescribing these drugs for patients of heart failure? In fact, 67% said probably yes. What are the potential concerns for us when we want to start these drugs? And very understandably so, lack of experience, concern for hypoglycemia, and need to adjust baseline medication. Nearly 55% thought so. So we'll discuss this in the discussion when we come, but it just confirms that even the cardiologists want to come forward to act as stakeholders to incorporate this drug in our contemporary arsenal. So we want to change our mindset. The final message is, advantages are a OD dose, doesn't cause significant volume depletion, which Dr. Sampath will also teach us, doesn't produce much of hypotension unlike ARNI, no need for critical up titration, doesn't cause worsening of renal function. Just ensure that the eGFR is good before you start these drugs. Check renal parameters, which again sir will talk about. Diuretic dosing might need to be reevaluated, but it's not mandatory. You don't need to downscale the diuretic dose until unless required. And glucose lowering therapy may need down titration if the HbA1c is at target. But by and large, significant hypoglycemia does not occur, even in non-diabetics. And of course, you should, think about peripheral vascular disease or other risk factors for limb amputation if you are considering this drug. So to conclude, I believe serendipity, that is, a chance is to be credited for many advances in medicine. And the story of SGLT2 inhibitor is nothing short of that. EMPA-REG just found that these drugs were benefited. And now the data now tells us that these are great drugs which should be kept in our therapeutic armamentarium. DAPA has started the journey of using these drugs in heart failure beyond diabetes. And as Packer very rightly said, these drugs give us a parallel path. They represent a new foundational therapy for heart failure so that we can lay a new roadmap for heart failure, systolic heart failure therapy, so that patients get the maximum opportunity to get the maximum benefit. And this is what is it, Fantastic Four, ARNI or SGLT2 inhibitors. It should no longer be a choice between them. We have to think about all four, that is MRAs, ARNIs, SGLT2 inhibitors and beta blockers. Thank you. Thank you for your attention.
Thank you, Dr. Aditya Kapoor. As usual, it is a very, very comprehensive as well as a beautiful talk. I think I will reserve my comments to the end because you have just floored. In fact, what is said is stolen the show. But it should not be a unilateral, let's say, it should not be just a unilateral appraisal. Certain picks must be given, must be done before we come to where and when and how we will use these drugs. So I give my point of view after the talk. And second, we have a speaker here, Dr. Sampath Kumar, who is a very senior consultant nephrologist in Meenakshi Mission Hospital. He is a DNB from Meenakshi Mission, and he was established first center in Tamil Nadu, which is actively involved in training DM nephrology. He has
So you need to unmute first.
Sorry, so what I spoke is probably inaudible. So first of all, I must congratulate Dr. Aditya Kapoor for this wonderful talk. In fact, one can say he has floored. So there is no opposition left. However, the fight still continues. I'll just give my impression about the drug, about the trials in the end. And as usual, he has set the standards. Kudos to Dr. Aditya. Well done. Now we have another excellent speaker, Dr. Sampath Kumar. He is a senior consultant nephrologist. He was trained in Meenakshi Mission Hospital and he started a DNB program there. He has been Vice President of Indian Society of Nephrology, Southern Chapter, and Nephrology Association of Tamil Nadu. He is a member of International Nephrology Committee of International Society of Nephrology, and he has received a very prestigious Dronacharya Award for Nephrology in the ISW Council CNR IBN 2019. He has more than 50 articles, and I am waiting to listen to Dr. Sampath Kumar. We will be starting our discussions in end now. So, Dr. Sampath, over to you.
Thank you. Thank you, sir, for this great opportunity. Aditya Kapoor has scored a brisk century, I should say, and so the first one-down batsman, has a lot of performance to do. So I'll just the difference between his approach and mine will be that I will not stop short only with the SGLT2 inhibitors. I will just give an overview of management of chronic kidney disease in stage 3 and 4, possibly because of the reason that physicians are very well versed with almost all the cardiological aspects of medicine, but unfortunately that cannot be said about the management of chronic kidney disease. In fact, when I was a MD postgraduate, my my knowledge about chronic kidney disease was very, very limited. So this is a field which is now opening up. And so as far as the chronic kidney disease is concerned, India is happens to be one among the hotspots in the world. Close to 7 to 10% of the adult population in India have evidences of chronic kidney disease. And what are these evidences? Either they have a low glomerular filtration rate, less than 60 ml per minute, or they have proteinuria, or they have abnormal imaging of the kidneys, which has been there for more than 3 months. So this is how we define chronic kidney disease. And when you come to the grades of chronic kidney disease, you have two categories. One is how low can the glomerular filtration go down, and how high the albuminuria can ramp up. So you have this typical heat map where the cardiovascular risk is being cartooned here. You can see that somebody is in the green part of the heat map when his GFR is more than 90 with very limited or almost nil proteinuria. But once his GFR is still on the above 90, when he has proteinuria in the range of between microalbuminuria or macroalbuminuria, you can see that the cardiovascular risk already is at the amber. And when we come to a patient with a chronic kidney disease in stage 3, you can see that he is already at a very high risk with proteinuria of cardiovascular endpoints. And the reason why we have to continuously inform about the difficult problem of management and diagnosis of chronic kidney disease is that it's a great mimic. Most often the diagnosis of chronic kidney disease is not made by the nephrologist. It is made in various clinics across the hospital, busy hospital. From gastroenterology, you will have referrals for somebody with anorexia, from cardiology with somebody with hypertension or heart failure, in hematology, anemia, in obstetrics and gynecology with menorrhagia or infertility, in the neurology from CVA or encephalopathy, in pediatrics with marasmus or kwashiorkor, even from dermatology, and also in orthopedics. So it's a great mimic, and by the time the patient is made aware of this chronic kidney disease, already the game is up, and we have little else to do than preparing for dialysis. So the causes of ESRD are multiple, and you know very well that diabetic nephropathy and hypertensive renal failure tower over the other causes. Other things like chronic glomerulonephritis are really important, calculate disease, and also a smattering of autosomal dominant polycystic kidney disease and other causes. Now when we come to the management, the first aspect which has undergone a slightly shift in our management is the dietary recommendation. We have always read that animal proteins are the first class proteins, but now we have gone away from a typical animal protein based diet to a plant based diet as far as the chronic kidney disease is concerned, because plant based diets have much to offer as far as the mitigation of progression of chronic kidney disease, because the alkaline diet will act in a way that the acidosis is corrected. And the second aspect is the vegetarian diet has got a lot of dietary fibers, so which increases the colonic excretion of the uremic toxins, and the proteins which come from the diet, especially from the dietary vegetarian diet, have lesser amount of phosphate getting absorbed because of the absence of phytases in our gastrointestinal tract. In contrast to animal protein based diet where phosphate absorption can be accelerated. And we always think that the high vegetable and high fruit diet will increase the risk of hyperkalemia, but think again, when in the early stages of chronic kidney disease, these diet are the ideal way to go about, because the alkalinity of this diet will drive the potassium inside the cell, and so there is little risk of hyperkalemia in when you advise a plant-based diet. They have been shown to reduce the progression of chronic kidney disease. So what do we have? Foods to include are 2 to 4 servings of fruits, high fiber, rich in vitamins and minerals, more than 5 plus servings of the non-starchy vegetables and legumes and nuts and seeds. So we need to exclude fruit juices, vegetable sauce, highly processed foods because they contain high amount of phosphorus which can get quickly absorbed from the diet, meat, and also to some extent the dairy products. So what about the exercise? It has been again shown that early stages of chronic kidney disease, you need to have a good exercise program because it produces a reduction of the progression of chronic kidney disease. What about blood pressure control? So the standardized method of office blood pressure reading should be incorporated rather than the type of blood pressure monitoring which is important. For example, I will not say that you have to throw away all the mercury manometers. We still have a lot of role for them. Even now I measure the blood pressure with the help of mercury sphygmomanometer. So it has got a role and you can use this, and especially you need to give the patients at least 5 minutes of rest and then start recording the blood pressure. At least 2 readings should be done in every patient. The goal systolic blood pressure is slowly coming down with every passing decade. Now in the chronic kidney disease in KDIGO recommendations, it has come as low as less than 120 millimeters. This goal is difficult to reach in patients. Most of our patients with chronic kidney disease with that resistant hypertension. Initial drug should be a RAS inhibitor. Never combine ARBs with an ACE inhibitor. And ideally, most of the patients with chronic kidney disease should receive a combination of a RAS inhibitor, calcium channel blocker, diuretic, and also a beta blocker. And close monitoring of serum creatinine and potassium is required to start and also during the dose titration. We nephrologists are not so lucky as the cardiologists who have undertaken major trials, cardiovascular trials across the continuum of cardiovascular disease over the last 50 years, and they have given us great benefit as far as the evidences. We nephrologists are a bit, I will say, lazy. We have never taken up large scale studies in our population. The only study which we can say with confidence has been done way back 20 years ago, the renal study and the IDNP study, which gave us the information that RAS blockers and can be used in patients with chronic kidney disease to retard the progression. And over the last 20 years, we have been really at a stage of evidence desert, and we didn't know where to look. So RAS blockers, there are 2 therapeutic hurdles. We have a wide choice. Which do I use? So ideally, you should go for a molecule which has got a 24 hours action rather than a short acting drug. So a drug like telmisartan or azelsartan will be a good drug. And AC and ARB combination, I have already told you that this is not a good combination to have. So rather not take it up. Hyperkalemia is always a risk in patients as the GFR comes down, because kidney and colon are the 2 major organs which are responsible for potassium excretion. And when the patient goes in for a progressive chronic kidney disease, he doesn't take much fiber, and there is also less intake of food, and so there is constipation as well as reduction in GFR. So the stage is set for hyperkalemia. And especially when you add a drug which reduces the potassium excretion, then there is a real risk of hyperkalemia, especially when you are not following it up regularly. So this is especially a problem during this pandemic period, when we have our prescription really putting up for a long time. So risk of worsening renal failure. So all RAS inhibitors are equal, but some are more equal than others, like molecules like long duration of action, which will protect from the early morning surge of blood pressure. The AT1 receptor affinity is also very important, because even if you don't, if you forget to take the drug for 24 hours, if the affinity is good, then it is going to have a long duration of action. Collateral effects like uricosurium, which is specific for losartan, PPR gamma stimulation, which is specific for telmisartan. So the problem of hyperkalemia frequently plays spoil sport, as we have seen in this how rain played spoil sport in our centenary test. You have seen that hyperkalemia, we are not able to provide the benefits of RAS inhibitors for majority of our patients in chronic kidney disease. You can see that this outcome trial showed that more than 60% of patients who were started on RAS blocker had to down titrate or discontinue RAS blockers because of the risk of hyperkalemia. So when you have when you are reducing the dose and reducing or discontinuation of the RAS blocker, you are not providing the benefit. So this provides increases the cardiovascular mortality. So heart failure increases. So this is a real problem where you have twin dangers, dangers of hyperkalemia and dangers of RAS withdrawal. So what is the safe pathway for somebody? You need to use RAS blockers with potassium binders. So we have potassium binders which are coming up. Possibly they will hit the stands in a couple of months in India. So these are therapeutic enablers which will allow the nephrologists and also the cardiologists to use RAS blockers at their maximal doses for therapeutic benefit. So there are two potassium binders which are very useful: sodium zirconium cyclosilicate and patiromer. So you can use these and provide the benefit of RAS blockers. Now we will come to the main agenda, that is the control of blood sugar. And not only that, we always, there is an English saying that an apple a day keeps the doctor away. As luck would have it, the apple tree bark was the starting point of this journey of SGLT2 inhibitors, because the fluorescein, which is the initial product of the SGLT2 inhibitor, was obtained from the apple tree bark. And this was the basic science workup was done way back in 1980s, and it was quietly forgotten. And then came the cardiovascular risk outcome trial, which is the EMPIRE outcome trial, where we have the a glimmer of hope for the nephrologists, because it provided 46% risk reduction in composite renal outcome versus placebo. So this was a trial which really sparked enthusiasm among the nephrologists. And again, other trials came in, gave us the real same information, CANVAS and the DECLARE-TIMI trial. So all these gave us an information that in early stages of chronic kidney disease, say in the green segment that I have projected earlier, these are all in the nil albuminuria and also stages of CKD, very early stages, so much so that they will be never seen by the nephrologist. So we see patients only at the stages of stage 3, stage 4, stage 5, and so what do we have for them? So this is where the CREDENCE trial, which gave the information that in the stages of stage 4, with a stage eGFR between 30 and less than 90, and albumin creatinine ratio more than 300. So these are the type of patients that we see day in and day out in the clinic. And you also have the DAPA-CKD and the EMPIRE kidney trial, which were really useful for our people to gain the confidence that we can use these for our patients. So the CREDENS trial gave us the information that there is a 30% risk reduction versus placebo when you use it over and above the standard of care with ACE inhibitors, and also blood pressure reduction with multiple drugs in patients with diabetic renal disease. So the primary outcome, end-stage renal disease, doubling of serum creatinine, and renal or cardiovascular death all were reduced. And so the number needed to treat was also very good. We needed to treat only about 15 to 70 patients to gain one benefit. And as we went ahead with the multiple trials, we were also wiser and reducing the need of major amputation, fractures, etc. So as we went along, just like how we became wiser in the COVID saga, during the early phases of COVID, we didn't know what hit us. And then as we grew along with the COVID, we are able to design our trials in such a way that the benefits were more, the side effect profile was less. So CREDENS was also such a trial where less amount of side effects were seen. The safety profile was very good. Then came the DAPA-CKD trial, which raised the bar higher, and which took not only diabetic chronic kidney disease patients, but it also took up patients with non-diabetic renal disease. As Professor Kapoor told us, that even in non-diabetic chronic kidney disease, the benefits were there all to see. The ischemic hypertensive nephropathy, IgA nephropathy, focal segmental sclerosis, membranous nephropathy, all these also derived benefit. And you can see that the number needed to treat was only 19. The relative risk reduction was to the tune of close to 40%. So CREDENS trial was a diabetic trial which gave us a benefit that there was a 30% risk reduction. The DAPA-CKD was both diabetic and non-diabetic trial, again gave us the same benefits, that you are able to reduce the progression and also renal death. So this is a very, very good thing to have. So I'll just briefly tell you about how these benefits could be accrued. We know that patients with normal renal function have a tremendous glucose reabsorption in the proximal tubule. More than 90% is reabsorbed and facilitated by the SGLT2 inhibitors, SGLT2. And so you have only 10% glucose reabsorbed by the transporter SGLT1. But in patients with diabetes, the activity of this SGLT2 and SGLT1 are increased multifold. So they are able to reduce this tremendous reabsorption of glucose. What really happens, what we think is happening, is that the proximal, the afferent arteriolar vasodilatation, which is always is a risk factor for the glomerular filtration, intraglomerular hypertension, is negated. So when you give a drug which increases decreases the activity of the SGLT2, so that more glucose comes across, not only glucose but also sodium comes across to the distal tubules, you have a situation where there is a reflex vasoconstriction of the afferent arteriole. So when the afferent arteriole is vasoconstricted, the delicate structures, especially the podocyte inside the glomerulus, is protected by the by reduction of the glomerular hypertension. And this is what we thought that is protecting the kidney. But now we have some evidences that it may not always be the truth, and we have evidences which are coming up that SGLT2 inhibitors act just like ACE inhibitors and ARBs by increasing the efferent arteriolar vasodilatation. So just like how how these RAS blockers act, the SGLT2 inhibitors also are acting at the efferent arteriole and produces the vasodilatation. So this is how the benefits accrue. As our chairperson is ready with his guns blazing, that about the multiple side effects of these drugs. They are not drug which can be given for all and sundry. You've got to choose your patients, and I really appreciate his efforts, because the risk of renal genitourinary infections, increasing diabetic ketoacidosis, acute kidney injury, all these are there, hypotension. So you have to choose your patients and also monitor these patients, especially during the early stages and also when they are sick. For example, when a patient with chronic kidney disease and diabetes develops COVID, gets admitted, so SGLT2 will be the first drug to be taken off. So the acute care involves stoppage of drugs, and SGLT2 inhibitors should be stopped in patients who are critically ill. So multi-targeted approach for chronic kidney disease, as I already told you about all these. I'll just run through the cardiovascular risk in chronic kidney disease. Supposing 100 patients start with stage 3 chronic kidney disease today, what is their fate over the next 10 years? 65 of these 100 patients will die a cardiovascular death, and 27 will be on regular follow-up. Only 8 will be requiring dialysis. So you need to focus on the cardiovascular death and the cardiovascular events of these patients with chronic kidney disease. One of the problems that we face is, you can see the radial artery of these patients with chronic kidney disease like lighting up like a pipe stem. So this is a calcified radial artery. So you can imagine the calcification of the medial artery, just like how coronary calcification is extremely common in patients, and this is a contributor towards the high coronary events in these patients. And the beta blockers are required for these patients because they give a survival advantage for patients with chronic kidney disease. I will not go into the details of all these because the time is short. I'll just run through these slides to tell you about the multi-pronged approach that we require for chronic kidney disease. So phosphate retention drives the vascular calcification. So you need to reduce the phosphate absorption from the diet by dietary restriction, increasing the plant-based diet, avoiding calcium containing phosphate binders, restricting the use of vitamin D analogs, and of course periodic monitoring of calcium, phosphorus and PTH. Metabolic acidosis again drives the chronic kidney disease by multiple pathways, and it can lead on to interstitial fibrosis and progression of chronic kidney disease. So this is where a very cheap tablet, they are called even baking soda that we use in the kitchen, the sodium bicarbonate can be used to reduce the progression of chronic kidney disease, up to 3 to 6 tablets depending on the acidosis. Mind you that it can increase the sodium load and also increase the hypertension. So the sweet spot of the bicarbonate should be between 24 to 26. If you go beyond 28, there is increased risk of calcification. If it is below 22, again there is bone demineralization and increasing risk of death. And so you have management of anemia, again a big topic. I'll just skirt through and say that anemia has to be managed. The iron deficiency should be looked into, and early stages you can give erythropoietin. Now the era of the orally available drugs which are coming in, again prolyl hydroxylase inhibitors are coming up, and so they can be given orally to increase the erythropoietin generation. And so we have trials coming up. We need to wait. The uric acid saga has considerably dwindled. The enthusiasm has dwindled because a couple of trials have shown that by reducing the uric acid, progression of chronic kidney disease cannot be halted. One factor which is important is that when the uric acid produces uric acid crystals in the urine, then it is likely that uric acid reduction could be useful. Very important slide. You can't make a diagnosis or put the CHAPA of chronic kidney disease in every patient before you need to exclude reversible causes. So multiple reversible causes like hypovolemia, congestive cardiac failure, glomerular diseases, drug-induced diseases, all these have to be excluded with a very careful history taking, urine analysis, ultrasound and renal biopsy before you can label somebody as irreversible chronic kidney disease. So different trajectories of chronic kidney disease, if the trajectory is very downgraded, then it means that there is something else is happening as a renal toxin like drugs, toxins and infections. So all these have high awareness. For example, for non-steroidal anti-inflammatory drugs, aminoglycosides, you have radiocontrast agents, everybody is aware, but easily missed are the alternative drugs with heavy metals, PPIs and multiple antibiotics. So all these are causes of high risk of progression of chronic kidney disease, pregnancy, snake bite, prolonged dialysis, etc. So vaccination is again important. And so this is the closing slide of the alphabetical order at which the multi-pronged attack should be carried out. A stands for the albuminuria reduction, anemia management. B stands for blood pressure reduction. C for calcium, phosphorus, PTH control. D for dyslipidemia management. E for electrolytes, acid-base balance. F for failure, cardiac failure prevention, and G for glucose control. So we will add N. This N stands for nephrology referral, because creation of dialysis access and exposing the chances of renal transplant, financial implications of dialysis, all these are important. So we need to have nephrology's referral at the right time. Friends, I will close now. We'll be ready to take the questions. Thank you very much.
Thank you, Dr. Sampath. It was a beautiful presentation, at least for a cardiologist. And I have learnt a lot, no doubt about it. Particularly, I would like to highlight because till 10 years back, it was that fruits were a no-no and the vegetables were a no-no. But it is an eye-opener for me, let me acknowledge. It was a beautiful presentation, at least for me. So you have discussed CKD, how to manage, how to halt the progression, and you have touched upon how SGLT2 inhibitors may be useful. So since this is the ongoing talk, I think we will try to talk about here. One thing I'm always wondering, and that is what they did in DAPA-HF trial also, is that they take as a deterioration of renal function as a GFR by a reduction by more than 50%. Why is it so? Why not 25%? Because let's see, at the age of 70 or 75, the GFR 50% reduction would mean that he is landing from, let's say, 60, 65 suddenly to 30. So wouldn't that be too much? Is it not that you come by one grade? Now, why I am saying is that if you see the DAPA-HF data, in fact, the creatinine increased. And the creatinine increased by 0.07 as compared to 0.03 in the placebo limb. But still, since they went for a 50% reduction in GFR, it said that no, it doesn't impact the GFR. And then in the Emperor trial, they have gone to show again the crossing of GFRs. When they cross at let's say about 6 months, the GFR earlier comes down with the empagliflozin, and later it scores. Now that is a bit, I'm not able to grasp why they keep such a high level of GFR reduction as the effect of drug, rather than 25% or 1 grade reduction in GFR. Any thoughts on that?
Yeah, see, the reason is we have learned from the use of RAS blockers during the 1980s that there will be a sharp drop of GFR when the glomerular hypertension is relieved. And that drop will translate to anything between 25 to 30%. And that drop, if you are going to stop the drug at that time, then you are not going to give the benefit of the drug for long-term renal protection. So that is why they went ahead boldly, even when there was a sharp drop in the earlier period. We had that education from the RAS blockers that we have used time and time again over the last 20 years, that the early stage reduction is a biomarker of glomerular hypertension. So it is just a marker of glomerular hypertension. So we know that this is the glomerulus which is acting at a high pressure, and that is why the GFR is kept at a level. So the GFR comes down by a factor, and then it remains stable over many years. So this is the education that we had from the early trials of RAS blockers, and though we said that we are not going to stop the drug when there is a reduction of 25%, we are going to go ahead. So we have seen that over the last next 2 years to 3 years, the benefits are there to see. The renal benefits are there.
Right. Okay. Now there are certain questions which are pointed towards you. Dr. Swati Sharma is asking, can dapagliflozin be started with heart failure reduced ejection fraction with AKI during hospital stay? These are two aspects.
Yeah, I wouldn't start DAPA. I wouldn't start SGLT2 inhibitors in anybody who has got an acute illness. Maybe cardiac diarrhea, fever. All
something
these are
that to be taken care of first, and then second question relates to you is from Dr. Chatterjee. Which drug do you recommend to your albuminuria CKD patients to reduce albuminuria after ARB and ACE?
So once
he says that he asked that which drug do you recommend to your albuminuric CKD patients to reduce albuminuria after ARB and ACE inhibitor or ACE inhibitor? That means both are preventing albuminuria. There may be some patient which is the reason may be different. Any answer to that?
No, again, SGLT2 inhibitors can be added because they have been shown to reduce the proteinuria. But the important point is that the maximum tolerable dose of ACE inhibitor and ARB should be reached before we go for the next drug. So, ideal that you go for, say, 80 milligrams of telmisartan, and sometimes if we are very carefully following these patients with the potassium being in the normal levels, we go even up to 160 milligrams of telmisartan, very close follow-up.
Tolerable dose, maximum as used in the trials. So always try to go on that. Then another question from Dr. Rahul Jain. What are your comments on use of spironolactone in cardiorenal syndrome? He has not specified which type he is talking about. It's a broad question.
Yeah. Spironolactone, again, our concern is hyperkalemia. So most often our brush with spironolactone is only to strike off the spironolactone from the cardiologist's prescription. So rather than using it as a new drug, because most often we are hampered by the problem of hyperkalemia. Possibly with the advent of these newer potassium binders, which we are very eagerly awaiting, the problem is the cost. If we are cheap, we will be using it in large number of patients, and we give the benefit of spironolactone also to our patients.
So what I generally teach my residents is that one should use spironolactone particularly in two situations. Once when it is associated with hypertension, associated with uncontrolled hypertension, then you must use it. And the concern here is not the GFR but the potassium. So you have to be very frequently monitoring the potassium, maybe every week. And second situation is when their creatinine is rising, but the patient is having this creatinine rise as a part of preload, where the heart failure is not being controlled. Since the benefit of spironolactone is much more, there again in hospital we would start spironolactone and to follow it up. Then comes from question from Dr. Prasad, up to what eGFR can we use DAPA along with metformin in type 2 DM?
See, metformin and DAPA, they can spell trouble when the GFR comes down, because I have treated metformin-induced lactic acidosis in patients with a GFR of around 20. The lactate levels of 20 I have seen. I have dialyzed these patients. So you have got to be very careful about the problem of acidosis, lactic acidosis. Second is SGLT2 inhibitors also have a propensity to produce ketosis, and we have seen normoglycemic ketosis, and I have managed patients with a bicarb of 1 milliequivalent. So it can be a real problem. So we have to be careful when the GFR is coming down not to touch this combination, especially when the GFR is below 30. I wouldn't use it.
But the DAPA has been used up to 60. Less than empagliflozin has gone even up to a lower level of 30 milligram. So
but this combination,
that may be cut-off level, particularly with the
combination will be
metformin. Yeah, correct. Then Dr. Vijay Bajaj wants to know, is there any role of vitamin D in stage 3 or 4 CKD?
So when you have vitamin D levels are low, most of the Indians, my vitamin D levels are only 4. So most of us never venture into the hard sunlight. So almost all of us will have a low level. So it is ideal that you give a therapeutic dose of vitamin D and bring it up to close to 30. Beyond that, it is not going to be useful. So check the vitamin D levels. If it is low, use it, but not as a therapeutic drug when you use it in patients with stage 3, stage 4, because vitamin D increases the phosphorus absorption from the gut, and so hyperphosphatemia is a very, very real problem.
Once you are using therapeutic doses, then you have to be cautious about hyperphosphatemia rather than anything else. And please don't be guided by your vitamin D levels in that situations, unless it is extremely low, because the reporting is not consistent. Then Dr. Prakash Moge wants to know, are there any oral drugs for increasing erythropoietin?
That is what I was telling, that the oral drugs are coming up. These are the prolyl hydroxylase inhibitors, which have been trialed in the Western population. Possibly they will be coming in another 6 months to 1 year's time to India.
Yes. Thank you, Dr. Sampath. And now we switch over to Aditya. So before that, I would like to share some of my thoughts about this. Actually, I am very afraid of using when there is a new drug in the market, and particularly when it is being developed by a pharmaceutical giant, and there is a lot of noise in the literature. Then I'm afraid. So I think I am the last person to use a new molecule. So the same is with dapagliflozin and empagliflozin. I am still not very, very frequent, particularly if I do not know the mechanism of drug, how it is helping in my patient, particularly in heart failure, how it is helping. The only impact that we know is that it's glycosuric and it produces water loss. Beyond that, every other thing is a hypothesis, and none has been proven till date. Now, why should it? So, We know that a patient, diuretics are the mainstay of therapy of congestive heart failure. And if you ask me to name one drug which reduces the heart failure hospitalization, I would say diuretics, and we don't talk about them. Because diuretics are poor cousins. There is no company which is going to start a trial on diuretics versus placebo. It is not, cannot be thought of. But if you go to literature, then diuretics have been tested only in very small number of patients compared to placebo. There are only 4 trials where they have been compared against placebo, and you will be surprised by the extent of mortality reduction that they do. It is to the tune of 75% reduction in mortality. This is unbelievable, but we don't talk about it. Second thing is heart failure hospitalization. There is no prize money for that. They reduce the heart failure hospitalization to 100. The figure is 92%. Now remember, these trials are very small. In all, there have been 269 patients divided in 4 trials. So diuretics are best drugs as far as symptoms are concerned, and probably the most potent to reduce the mortality. None of the drugs have reduced mortality to 78%. But now, so once this drug came first in diabetics, what was seen that it is reducing the heart failure hospitalization. Naturally, the next step was to go into the heart failure therapy. Now, if we go to dapagliflozin, the trial, they've never mentioned whether it is single-blinded or double-blinded. I believe it is single-blinded. Emperor is double-blinded, they've mentioned it. Then diuretics, can you recall a patient of your heart failure patient who is not, you are not giving diuretics? In this trial, nearly 10% patients were not on diuretics at all. And the cutoff has been kept at 40%. If you see the age and weight of these patients, they were nearly 28. The BMI was 28. That is going up to a level of obesity. So they were obese patients who were minimally symptomatic. 2/3 of them were NYHA2. Now, when you NYHA2 is our interpretation, but when you go from the patient's point of view, a scale of 100 being asymptomatic and 0 being severely symptomatic, of 1/3 of the patients in Emperor trial were in NYHA1, but they were labeled as NYHA2. On patients' criteria, their score was 90 out of 100, which can easily fit into NYHA1. And if you analyze the data of DAPA, NYHA class 2 did not benefit. So, beautifully, they had kept a cutoff level of 40%, so as to increase the size of this. But even with 40% ejection fraction and a population as large as 4,000, the benefit was not seen in mortality. In DAPA-HF, it was a combined endpoint. Mortality was not separate. And secondary endpoint should not be heavily relied on. In fact, in Emperor heart failure, mortality was not reduced, even on secondary endpoints. So mortality is not in question. The only question where these drugs they score is heart failure hospitalization because of their diuretic action. Now, they have not mentioned what was the diuretic dose at the beginning and what was the diuretic dose at end. Now, if you see the articles recently, they say that if the patient is in dapagliflozin or these gliflozins, you can reduce your diuretic dose to 25 to 50. Why so? Has that happened during the trial? If it has happened and you have reduced diuretics, you are bound to get a benefit of another diuretic, which is glycosuric. So it is not a rocket science to believe that it is working as a diuretic, and that is why it is giving benefit. We don't have any trial or any data suggesting that it is better than diuretic, because then the diuretic dose should have been mentioned. Secondly, there is an ongoing World Cup cricket going on, the champions of test. So if you remove Virat Kohli from Indian team and Ashwin from Indian team, who are you left with? That is what exactly has been done. Now they have been not compared. Today, in the current era, the therapy would be beta blockers, diuretics, not ACE inhibitors, but combination of drugs where you are using, on the basis of paradigm heart failure, you are using some other drugs. I would not go into them. So, and in DAPA-HF, what they have done? In DAPA-HF, sacubitril/valsartan was only received by 11% patients. And when they analyzed the data, there was no benefit in them. In fact, the empagliflozin did not analyze that data. So only 10% in DAPA-HF and 20% in EMPA-HF had the combination of sacubitril/valsartan. Now, we have been using sacubitril/valsartan and is compared to a biventricular therapy. The symptoms are so pronouncedly reduced that you cannot negate that. And if you see the symptomatic benefit of these patients, they have not assessed that. They have not mentioned that. In fact, there is not much symptomatic benefit, but the heart failure hospitalization have been reduced. That is why NYHA2 patients have not benefited. It is only NYHA3 which is benefited. So a hypothesis from DAPA-HF that NYHA3 will benefit, that means more severe reduced ejection fraction will benefit, has been proven wrong in empagliflozin trial, where lower ejection fractions did not have a mortality reduction. So what I understand from there, if I see further the trials, if you see the BNP levels in the drug treated arm at the end of the trial is 200 to 300 units lower. What does that mean? It is an indirect indicator of the left atrial pressure or the atrial pressure. BNP indicates the pressure characteristic or the filling pressures, whatever you call that. So they are giving that data that yes, there is a weight loss in DAPA-HF trial. There is a weight loss of 1 kg which correlates with pro-BNP difference of 300. And there, if you claim that it is because of drug, yes, it is because of drug, but that may be the diuretic effect of drug, and probably diuretics alone would have done the job. So I really do not know. Now, how would I take this? I would take it as I would give my patient a good diuretic, and that too, the loop diuretics. How would I decide that it is good? When I am at the verge where my creatinine starts rising, that would be the euvolumic, slightly euvolumic. The data says, the guidelines say that rising of 25% of creatinine from the basal normal level indicates good action of drugs, be it ACE inhibitors, be it beta blockers, be it diuretics. It indicates good action. And then I would add first the sacubitril/valsartan combination. And if still patient is symptomatic and it is not a female and the patient is not in atrial fibrillation, I would use the drug. But I would exclude my females. DAPA-HF did not show benefit. In atrial fibrillation patient, they behave differently. In atrial fibrillation heart failure, beta blockers don't benefit. Somehow, some reasons. So that only means that when the heart failure is marked, if you don't take care of preload, the beta blocker will not work. Atrial fibrillation is manifest by that. So I will select my population who is a male, who is in sinus rhythm, who has received all actual drugs and a diuretic in good dose. If you bring me a trial like that, I would really use that drug. But I am not taking away the credit, because most of our patients are coming to us as a naive patient. In those naive patients, there are situations when you need to start a drug. You can't use, classically a patient of less than 100 millimeter systolic pressure, tachycardia, bloated patient, I would use drugs, but there I can't use my beta blocker. I can't use my ACE inhibitors because the creatinine is higher. That would be a situation where in acute situation I would go for dapagliflozin. This may be another, that would be a situation where I would be using the ivabradine. You have not talked about ivabradine as another fifth drug to be used in the combination. So this will be then, that will be the role of using it upfront, but later on only when the patient remains symptomatic, not as a block therapy. Now, the question for you, Aditya, yes.
Sir.
You.
So I think the beauty of having Dr. Dwivedi on board is that he always, brings out new thought processes. So, and that is the, me and Dr. Sampath were sharing because Sir mentioned that he does not adopt new therapies very quickly, and I think that is the right thing to do. I mean, your enthusiasm should always be tempered with some degree of scientific evidence. So, if I may just be allowed to share my screen for a minute. I think Dr. Dwivedi, sir, is my screen visible?
Yes, very visible.
So I did not show this slide deliberately because you are absolutely correct that the original DAPA trial, the diuretic use is unquestionably, it should be used in patients who are volume overloaded, and you are absolutely right, these were patients who were moderate heart failure. And that is why for NYHA, maybe even class 4, these drugs should not be used, and I think Dr. Sampath also mentioned it, for sick patients, these drugs should not be used. So we should use these drugs very carefully because these are very good drugs, but again, to be used in the right context. And even in the DAPA HF, because of shortage of time, I did not mention, the trend was the more benefit was seen in NYHA class 2 rather than in 3. And class 4 were only 1%. So coming back to Sir's question, this was the original data which has been teased out now. Nearly 1/4 of the guys were on diuretic furosemide of more than 40 milligrams. So this has been published now. The hazard ratio was in fact preserved across the board of across the spectrum of diuretic dosages. But what you mentioned, sir, and that is again a great point that you mentioned. So dose change. At 12 months, 12% of the people in the DAPA had their dosages of diuretic actually brought down.
Yes.
So that was that the dose was not brought down due to volume depletion or hypovolemia. It was brought down due to symptomatic benefit. Secondly, the dose increase in the placebo arm was 14% as compared to only 10%. So that is as far as the diuretic thing was concerned. Your point is absolutely well taken. This is a drug to be used for moderate heart failure patients. And as far as the mechanism, and this is, you are absolutely right, this is the diuretic usage is 84%, as you mentioned, 16% were not on diuretics. Probably that was, as you also pointed out, these guys were moderate heart failure. So they were not really badly congested. And lastly, again, shortage of time, so I did not show this slide. Glucose lowering mechanism for these drugs is very, very unlikely because the reduction in HbA1c is very modest and the effects are almost instantaneous. Diuresis, as Dr. Dwivedi sir also said, does not explain the benefit. There was only a 10 to 15% decline in the pro-BNP. The diuresis, as Dr. Sampath would vouch, it is very mild. So, and people said rise in hematocrit, but now this is what Packer believes. Myocardial sodium hydrogen pump inhibition, which improves the myocardial calcium handling, shifting metabolism, because like metabolic modulators, these drugs shift the metabolism from carbohydrates, which is a bad source of ATP, to ketone. And lastly, this is again a fancy term, these drugs fool the body to think there is fasting mimicry. So again, what Dr. Dwivedi said, all these are mechanistic approaches which have been postulated, how far they are true. But I agree with Sir and Dr. Sampath that these drugs should not be used left, right, and center. Choose your patient and choose them well.
If you see what happens is that when a new drug comes, people jump on board with the drugs. Here is a drug, we don't know the mechanism of action. We know that the benefit is there, So the only when you use, you will come to know heart failure is such a population where anything which is working is going to save the life. The mortality in 1 year is 15%, 2 years, 5 years, the traditional data is 40% will be dead. So if you are gaining anything, you are going to use this. My only thing is that when one should not jump upfront with the drug. That is such a beautiful drug. It doesn't have any side effect. We did not talk about the side effects. We did not talk about much about where not to use the drug. There are females. This produces glycosuria, particularly in the elderly female who are not controlled sugar. The chances of infection are marked there. In fact,
Sir, I would just
you had shown this slide. Yes, you had.
Where I would not do this, NYHA class 4, acute decompensated heart failure, and as Dr. Sampath rightly mentioned, a guy in whom I am not sure what is his diet pattern going to be. He is non-compliant because, and prior to any surgery, these drugs have to be stopped 2 to 3 days prior. So if the patient is, the soloist heart failure trial in which one of the SGLT2 inhibitors were used in acute decompensated heart failure, it was in fact terminated early because the sponsor withdrew. But again, the data from that trial showed there was some benefit. So you're right that we are still, unsure about the mechanism, but I think one should have this drug in your bag so that when you want to use it, you should use it and not use it too late. You should not think that the patient is stable. So their therapeutic inertia has to be overcome.
Yes.
Our fear that it will produce hypoglycemia is not true. It does not produce hypoglycemia to a significant extent. And if at all you are worried about the hypoglycemia, you can have a look at the HbA1c or talk to your endocrinologist. But what I think the carry home message is that we should probably change our mindset and become a stakeholder in considering this therapy when needed.
Now, again, my worry is when we are treating patients, now the shift of the focus is not only to increase the life number of years, but the number of happy years as well.
Yeah.
Same Milton Packer had written an editorial that if a drug is making my life mess, but increasing my life expectancy, I would not go for that. So here is one drug which is making my life happy. It's not messing my life, as opposed to others like spironolactone, like ACE inhibitors, like beta blockers have potential to mess my life. However, all these drugs where we are adding, what we are doing now, right now, what I would say is that I would not keep this drug at the same level as ACE inhibitors, as beta blockers, as sacubitril/valsartan, as spironolactone, simply because of one reason. None of these drugs have any negative trial on cardiovascular mortality. All drugs in all trials have shown survival benefits in combined endpoint as well as independent endpoints. All these have shown benefits. Here is a drug where one large data set, DAPA, is in secondary endpoint, as a secondary endpoint, showing it as a benefit, and empagliflozin is not showing a benefit as a secondary endpoint. This is what is worrying me. Yes.
But again, this is a very good point, and this is the point of intrigue which was there, that in the Emperor reduced trial, to be very specific, the mortality benefit was 8%. In the DAPA-HF, the mortality benefit is 18%. So people started wondering, when EMPA-REG outcome showed a 38% mortality benefit,
Yes.
why should not Emperor reduce show a mortality benefit? So again, Packer came out with this clarification that the reason is that the ejection fraction was lower in Emperor reduced. Their eGFR, Dr. Sampath will vouch for it, their eGFR was 61 versus 66. In the DAPA-HF, the eGFR was higher. 20% of the Emperor reduced were taking ARNI. So these are all the NT-proBNP was much higher. And in fact, when they shifted out the data, the number of numerical deaths in the Emperor reduced were slightly lesser as compared to the DAPA-HF. So it is just a chance occurrence. So because this is a class effect, we all know that it's a class effect. And
So in the other way,
and just last one information on the basis of Emperor reduced, which did not show a mortality benefit. Day before yesterday, European agencies have approved empagliflozin also for heart failure.
I am aware.
Just a chance occurrence, and I take your all your points. They are absolutely correct. That we should at least have it in our bag at some point of time.
Certainly.
I would probably in the last few months, I have changed my mindset that I have become slightly more open to adding it. But again, with all the precautions which you or Dr. Sampath had mentioned.
In the same vein, I am saying that when 10% population is using sacubitril valsartan, there is a survival benefit. When 20% sacubitril valsartan use was there, there was no survival benefit. It can be taken both ways. And what Milton Packer is saying is purely based on the hypothesis rather than evidence. There is no doubt that it is reducing heart failure hospitalizations. I am not bothered about the mechanism. What we are doing here is discussing the probable mechanism because none of the mechanisms are explaining it. But the fact remains, right from the trial number 1 till now, it is reducing heart failure hospitalizations.
Absolutely.
Something like digoxin. Something like digoxin. Digoxin still has its beauty, still has its sparkle. So I would just keep this drug not at par with other drugs as has been promoted by the guidelines. Canadian, American and European yesterday came and gave approval. But Europeans have not changed, they have not published their guidelines as such, whether they should be considered same. I cannot consider them because there is no unequivocal survival benefits. There are voices strongly favoring that. Milton Packer, strongly favoring that.
Even based on one trial, paradigm heart failure, the guidelines changed and include ARNI as a class 1 indication.
So when we used it, we found that it is excellent drug and patients actually behave like they are on BIV device. That is why I said I am the last person to run in the race. And I keep on, I would say I am not a sprinter, I'm more of a marathoner type of a man.
What is Dr. Sampath's experience of using it?
How often you use Dr. Sampath?
Yeah, now I have a large number of patients who are on this drug. But the only issue is that they do come with urinary infection, genital infections, all these are there. So you have got to follow them up. And especially when they are sick with some other illness, if they continue to take it, they do badly. So all these trials were all very carefully handled patients. So you saw only the benefits. The side effects are down because of the very careful follow-up of these patients. When it is thrown to the population, it is upon the individual nephrologist and individual cardiologist to see to it that they are taken in the safe pathway. That is very important.
What I understand from your words is that when you control diabetes with the hyperglycemia to a reasonable limit, when you expect that glycosuria would not be that much, then you would use this.
Yes.
Probably.
Yeah.
So I don't see any other question in the chats. So it is almost, we have overshot the time. I am sorry, we have nearly overshot by half an hour, but it was wonderful. I would certainly start increasing the use of dapagliflozin, particularly in my patients. But definitely I'll be slower as I always am. Gives something for my age as well.
You are slower because you are more sensible.
Thank you. Thank you. Over to you, Gaurav. Dr. Mithilesh, over to you.
Sir, I am here. Good evening to you, sir. I am very, intriguingly listening to the critical appraisal of SGLT2 inhibitors. And, there are so many, I have attended almost 15-20 webinars in last 6-8 months since we introduced dapagliflozin in India, Dapawell.
But the sales now go down.
No, I don't think so. Because, sir, the perspective that you gave today, I think this perspective has never been discussed in any of the webinars. And this is something, we all are for. as an organization, as a company which produces dapagliflozin, because we want the patient to get the good of the drug rather than bad of the drug. And you need to choose the patient rightly, as both of you have very rightly mentioned that the right kind of patient should be chosen for the drug. And that is the reason, sir, we are organizing these webinars, so that the population, the physicians who are listening to you, we have more than 1,000 delegates today who have logged in, and they are getting to learn the nuances of using SGLT2 inhibitors. And I am really grateful to you for your thoughts and for your wonderful deliberations today. It is I missed out Dr. Kapoor's lecture because I was in flight,
It
and
was wonderful. It was wonderful.
yeah, but
I'm
I
sure
did.
if the sales drop, Amit, I am not the only culprit. Thank you.
Sir, India is country where there is no dearth of patients, and we are unfortunate in that aspect. The
There are
diabetes,
drugs, but there
Yeah.
has to be a patient for that drug. Rather than
Absolutely.
there is a drug which is there for every patient, I strongly believe that there are drugs and there has to be a patient for that,
Very
rather
well.
than doing the other way around. Only then we can benefit our patient. Thank you.
But your comment gave me a relief when you said that you are going to use it more often in your patients.
I would definitely use it.
So sir, I on behalf of Intas and Dapavel, I would like to say thank you for your presence today. We are really overwhelmed to have you here, Professor S.K. Dwivedi. I mean, it is very difficult to get you on such platforms and share your thoughts. Professor Aditya Kapoor, thank you very much, sir, for coming on this platform and sharing your lecture. Dr. Sampath Kumar, wonderful lecture. I heard his lecture fully, and your thoughts on the managing CKD. And as Professor Dwivedi mentioned, in between that, there was a lot of learning and great learning. Though I am not a medical person, but still,
Definitely.
there are a lot of things I pick up, and there are things which really make me learn a good amount of things. And I thank all the delegates who have joined in from different parts of the country for their presence today. And we had more than 1,000 logins. And so it's wonderful having you all. Thank you very much once again from all of us at Intas and makers of Dapavel. Thank you. And let me tell you, Dapavel is one of the most affordable brands in India. Just 9 rupees 90 paisa 10 for 10 milligram tablets. So that is the cost of Dapavel 10. So thank you very much, sir, and good night to all of you, sir. Thank
Thank
you.
you.
Thanks for your time.
Thank you, sir. Good night,
you.
sir.
Thank you, sir.
Good night.